Assalamu alaikum. The short clinical day. First scenario, please examine 55 years old male patient. Examine his cardiovascular system. Dr. Tabir, ready?
Okay, yes, ready.
Yeah, here you go.
Okay, so first I will enter the room. I will give the greetings to the examiner and I will wash my hand. I'll see what is written in the leaflet. 55 years male, please examine the chest. So I will go to the patient. I will ask her, I'm Dr. Ali, one of the doctors in the chest clinic today. I have been asked to examine your chest. Is it okay for you?
Okay.
Hello.
Yeah, doctor.
If you
Yes.
feel any pain or discomfort during my examination, just let me know.
Okay.
So after that, I will make that patient in the 45-degree angle, and I will remove the shirt from the chest and hand and leg area. Dress I will be removed. Then I will go to the surrounding. Is there any bedside surrounding, any sputum board, any ECG machine, anything there or not?
Cardiovascular.
Then I need,
Cardiovascular, doctor.
yes,
Dr.
yes. I will see
Tabir.
that any
Heart,
any
heart. Yeah.
anyway, I will see any instrument there beside the bed or not, even the ECG machine. Then I need to go to the general assessment to see any facial malar flash, any muscle wasting in the body or in the hand, leg, anywhere. Then I need to
Negative.
go to the leg. After the going to the leg, I'll tell after that you may tell me that what is the finding. So when I go to the leg, I'll see that from the leg in, is there any leg swelling? So, sir, do you have any pain in the leg? I just check the leg edema and I'll see at the same time is there any leg scar mark or not. Then I need to go to the front of the patient. I need to say that, sir, can you raise your hand, please? So I need to see any clubbing, splinter hemorrhage, any ossular node, genoelation, any pulmonary eczema, or jaundice, anemic looking cholionicia, leukonychia, anything. Then I need to
Negative.
go for anything positive till now,
Negative.
negative. Okay, till now everything negative. Then I need to go for the pulse examination. I need to count the pulse. I need to count the pulse rate, volume, any regularity or irregularity. I mean, high volume pulse or low volume pulse, regular or irregular. Is there anything there?
Yes, it is irregular.
Irregular, high volume or low volume?
Normal volume.
Normal volume. Okay. Then I need to do radio radial delay and I need to check, I need to offer for radio femoral pulse. Then I need to go, sir, do you have any pain in your shoulder? If no pain, I need to go for collapsing pulse checking. Then I need to see that JBP, is there any raised JBP or not? Sir, do you have any pain in your tummy? If there is no pain, I just need to make a C hepatojugular reflex. At the same time, I need to see any abdominal distension, I mean any ascites or not. Then I need to go for anemia and jaundice checking. I need to ask, can you open your mouth to see any mouth ulceration or any gum hypertrophy or not? At the
There
same
is
time, I need, sorry,
there is pallor.
what you said?
Pale eyes.
Pale eyes, okay, like anemic eyes, okay. Then at the same time, I still see any malar flashes, any parotid gland swelling or not. Then I need to go for chest inspection. I need to see any chest movement, any scar mark. I mean, any midline sternotomy or valvotomy or the intraclavicular, any scar mark or not. At the same time, I'll see any scar mark at the wrist or antecubital fascia or not. So, is
Yes,
there
yes,
any scar mark? Scar mark?
yes,
Anything?
yes. There is
Where the
midline sternotomy.
mid midline sternotomy scar mark? Okay, when I found that midline sternotomy scar mark, and I saw before there is a no leg scar mark. That means there is a no harvesting scar, no leg edema. Okay, then I need to go for, I will keep my stato over the sternum. I need to see that is there double click, any metallic click, double or single. I need to check with the carotid pulse if it's simultaneous with the carotid pulse or not. Then I
This is
need to move,
the
yes,
sound. This is the sound.
sound with the carotid pulse.
You can hear the sound. Just 1 minute.
Okay. I'm not listening actually. Anyway, it is metallic click.
It is not clear for you?
No, no,
You
not.
can, if you can
Not
read the
audible.
sound, yeah, read the sound, Dr. Atif, from the
I
laptop.
think it's a metallic. In the
Yeah,
metallic click.
there is like this, but we want to make it clear for others. If you can, please.
Yes, I raised the voice. But there
This
is
is
a
the
clear.
maximum.
Okay, no problem. Is this metallic click?
1 minute, Dr. Tanvir. You can hear
Okay.
now? Yes. 1 minute. Okay. You see now if you can hear.
Yes, it's a metallic click. Okay, so it is going with the carotid pulse. I need to check. Is it going with the carotid pulse or not?
Going with carotid pulse.
It's going with carotid pulse. Okay. Then I need to move my stator to the aortic area and mitral area to see any ejection systolic murmur or mitral stenosis. I mean, any diastolic murmur or not. I just move my stator to side. Then I need to go for auscultation of the cardiovascular system. I need to go for first I will keep the my stethoscope over the apex area, and I need to move from apex to axillary line to see any pansystolic murmur or not. Then I need to keep my stethoscope in the bell. I need to move the patient in the left lateral position. Sir, can you hold your breath, please? To see any like mid-diastolic murmur or not. I mean mitral stenosis murmur or not. So I checked already mitral stenosis murmur and pansystolic murmurs for MR, and I already checked that heart sound is a metallic click, soft heart sound. Anyway, then I go to the tricuspid area and to see any murmur to listen. Then I need to go pulmonary area and aortic area. Then I need to keep the patient in the sitting position and leaning forward. Sir, can you hold your breath to see, to listen the aortic regurgitation murmur? Then I need to go for carotid area by my bell to see any carotid radiation or not. So is there any murmur or any other things found in the auscultation?
Sorry?
Any murmur
Is there
there?
any?
Or only metallic click?
Only yes. That's why I did
Okay.
not.
Okay.
No murmur. No
No murmur.
murmur.
No murmur,
Okay,
yes.
so no murmur I don't found. Then I need to go to the, I need to check over that the chest, any thrill, any left parasternal heat, any palpable P2, anything there, I need to check.
Yes.
Then I need to go in the back to listen any chest tracheas and any sacral edema or not. Then I need to keep the patient again 45-degree angle. I need to go to the leg. I already checked already leg there is no negative.
Okay.
So
Yes.
is the left external hip or palpable P2 anything there?
Negative?
Negative. Okay, so I would like finish my examination by checking that vital chart. I mean blood pressure, oxygen saturation, and I need to do bedside ECG. And also I need to do urine for protein glucose.
Okay. So seems you're done, Dr. Tanvir. Don't forget to thank the patient
Yes,
and to
yes,
cover
I will
him.
thank the patient. I will again wash
Yes.
my hand. I will
Yes.
cover the patient again.
Okay. Let's start the examiner question, Dr. Atif, please. 4 minutes from now.
Okay. Okay, can you present your finding?
This is 55 years male person who is I examined this. He is the 45-degree angle. He is comfortable in the bed, and I don't find any bedside surrounding their equipment. And on examination, I found there is a 80 beat per minute irregular pulse, which is normal volume. And I found there is a pallor in the eyes, and also I found there is a midline sternotomy scar mark. With that, I found that there is a metallic first heart sound, and I don't found the feature of the pulmonary hypertension as there is a no evidence of the left external heave or palpable P2 or loud P2. I could not appreciate any audible murmur in the chest. And I don't find any chest crackles or feature of the pulmonary congestion or fluid overload, as there is no evidence of sacral or leg edema. And I don't find that feature of the infective endocarditis, which is evidenced by splinter hemorrhage or slur of generation. So above all of this, my finding, my probable diagnosis is it's a metallic mitral valve replacement evidenced by metallic first ultrasound associated with there is a pale anemic due to the I need to go for differential cause for anemia.
Mhm. What is your differential for the scar that patient has?
Sorry.
What is the differential for the scar that the patient has?
So midline sternotomy scar mark, I found actually there is an irregular pulse. So it's probably due to the mitral stenosis or can be the mitral regurgitation. That's why metallic mitral valve replacement done. But I don't found that murmur of the pansystolic murmur or ejection systolic murmur, the mid-diastolic murmur, but I found there's the irregular pulse.
Yes, what other differential for this scar?
It can be the first of all that the first differential is metallic mitral valve replacement. It can be metallic aortic valve replacement, but I don't found metallic second heart sound. It can be biological valve, but against that I found there is a metallic leak. It can be cardiac transplantation. It can be thymectomy.
Okay. What is the differential for this mechanical valve replacement?
Differential of the mechanical valve replacement, actually it can mechanical valve replacement for two purposes, mainly for mitral valve replacement or aortic valve replacement or double valve replacement. And I feel this is a metallic mitral valve replacement due to the mitral stenosis or mitral regurgitation.
What is your plan of management for this patient?
So my management is, I feel that patient is now stable, as there is no feature of pulmonary hypertension, pulmonary congestion, or infective endocarditis, but patient is anemic. So I need to check, I need to go for basic blood test, CBC, ASSCRP, and also liver renal function test, urine to see any blood there. Then I need to go for INR examination to see that any warfarin overactivity or underactivity. I need to go for chest X-ray, ECG, and echocardiography to see any arrhythmia, any cardiomegaly, or echocardiography. I need to see that valve functioning properly or not. I mean, any other valvular heart disease, any ejection, normal ejection fraction or not. And we need to, in this case, we need to rule out anemia, as there is a, it can be due to the mechanical hemolysis can be happen. So we need to treat for anemia, and we need to monthly regular follow-up in the INR clinic, and we need to do every 6 monthly echocardiographic follow-up.
Okay, what is your treatment? Yes.
So in this treatment, as I found, patient is now stable, no feature of the complication, but patient is anemic. So we need to rule out if there is a anemia according to the hemoglobin level. We need to treat that anemia. Also, we need to check that INR, that if there is a high INR, we need to adjust warfarin dose as it can cause this anemia or mechanical hemolysis. We need to see that any other infection associated or not. Mainly, we will do follow and also we will correct the anemia.
Okay. Can give the patient warfarin?
We need to check, yes, of course, if there is a valve replacement, patient should continue the warfarin. We need to check regular INR.
Okay. Thank you.
Okay, I will add one more question, Dr. Atif,
Sure.
excuse me. If this patient present to you with short of breath, what's your differential?
If patient present with shortness of the breath, it can be pulmonary congestion, I mean feature of the heart failure, or pulmonary hypertension. I need to rule out first.
What else?
And it can be infective endocarditis, can be arrhythmia. And also anemia due to anemic heart failure can also happen.
So if you want to examine again this patient and you find this patient again in your clinic and he came to you
Mm,
to the clinic with short of breath, what's your
yes.
expectation in the examination?
If this patient is anemic and patient coming with shortness of the breath, I will think about the anemic heart failure and any other complication. I mean, heart failure due to the other issues, pulmonary hypertension, infective endocarditis,
So
arrhythmia.
what you could find in the examination?
In that kind of time, I will found there is a slow murmur, like systolic murmur. I will found.
This is a separate complication, right?
Yes,
Like failure of the valve or non-functioning murmur or non-functioning
yes,
valve,
yes.
right? So you will hear murmur.
Slow murmur,
Yeah,
slow murmur. Yes.
yeah, okay. Or mitral regurg. You will hear a mitral regurg.
Mhm. Yes,
Okay,
yes, yes.
back to the
Due to
heart
the heart
failure.
failure.
Yeah,
Yes.
okay. So it could be like acute.
Mhm.
So what you will hear again? The murmur and
So if heart failure, murmur and basal crackles are all found.
yeah, and what else you will hear over the
And
chest
palpable P2, I found loud P2, I can found here
and by basal crackles, right?
bibasal crackles due to heart failure.
Yes. Okay. What other complication related to the murmur? Sorry, to the metallic
Valve replacement.
valve
Due
replacement.
to the metallic valve replacement, there is a multiple type of complication. First of all, due to the over anticoagulation, it can
Perfect.
cause bleeding, warfarin toxicity. Due to
Okay.
the under anticoagulation, it can cause thrombosis. It can
Perfect.
cause infective endocarditis, mechanical hemolysis, and also heart failure. And it can cause also arrhythmia, I mean atrial fibrillation.
Perfect. Okay, the last question. What's the indication for antibiotics if you suspect infective endocarditis?
If I suspect infective endocarditis, I need to take some history. Not nowadays, from the recent guideline, usually antibiotic is not used for genitourinary any procedure, dental procedure, or any like endoscopy purpose. But if patient had history of the infective endocarditis, history of
Yeah.
the prostatic heart valve disease, or history of the unrepaired congenital heart disease, we should get that time antibiotic.
Yeah. So tell me the indication now again.
So in the indicated, mainly that is
Previous.
there is a history of the previous
Perfect.
infective endocarditis,
And
prostatic heart valve
uh,
previously unrepaired congenital heart disease.
yeah, either repaired or partially repaired.
No, no,
Okay.
if
And
repaired, not unrepaired or partially repaired.
unrepaired or partially repaired. Yes. And
Partially repaired,
one more,
yes.
one more indication.
I forget any addition or something.
Cardiac transplant.
Cardiac transplant, better cardiac transplant.
Okay. Yeah, fair enough. I think for the metallic replacement or metallic mitral valve replacement. Let's start the comment, Dr. Rawatib, please. Can you comment then?
There is questions
Yeah,
I
okay, go
have
ahead, Dr. Aish.
because this is my case in the last
Okay,
exam.
go ahead.
For how long do you think this metallic valve can stay?
Dr. Tanvir, for how long the metallic valve?
What you said? I don't understand.
Lifespan of metallic valve.
Lifespan, yeah.
Lifestyle of the metallic bulb. Usually, metallic bulb is long durated, and we need to use lifelong warfarin. But
Yes,
there is actually no limitation like that. If you're maintaining this, I think it will be lifelong. But after 10 years, maybe it will deteriorate something. I'm not sure.
yes, it is about 15.
15 years. Okay,
15
that
years. Huh?
target
Yeah.
INA, if you have such patient, metallic
If that
valve.
mitral valve, it should be 3 to 3.5. If it's aortic valve, 2 to 2.5.
Perfect. And if there is
Yes,
AF,
If it will be up to the 4,
yeah, 3 to 4.
3 to
yes.
4.
Yes, perfect. Okay.
And
Thank you. Yeah.
how can you follow up by echo for يعني how frequent?
Echo, Echo usually, if no complications, 6 monthly, and INR clinic every monthly.
Yearly, echo yearly if no symptoms or any
It's a
yes,
symptomatic or no complication, we just follow up every 6 months.
yes. Okay. And other question, what is the indication of what is the cause of mitral valve replacement? Do you know? Or mitral valve lesion?
Mitral.
جنود الجيش الإسرائيلي
Okay.
يصرخون في وجه
No, this
نتنياهو
is two questions.
يجب أن تتوقف الحرب.
Lesion.
So if there is a
Okay.
two question, what is the indication of mitral valve replacement,
Yes.
and what is the cause of the mitral stenosis? What do you want to
Okay.
know?
Yes.
I mean the last question, but if you need for information for others
Okay.
to also answer the first one, no problem.
Okay, no problem. If mitral stenosis, fast rheumatoid heart disease. Second, we
Yes.
will count any calcified heart valve disease, any congenital issues like that for mitral stenosis. For mitral regurgitation, usually the cause is infective endocarditis, rheumatoid heart disease, chorda tympani or papillary muscle rupture, usually after MI, or connective tissue disorder like Marfan, aortic regurgitation, and sometimes it's related with some medication like pergolide, like that, which can cause a fibrosis. These are the cause of the mitral stenosis regurgitation, and indication of the mitral valve replacement.
Other causes,
Usually,
other causes.
Infective
For-
endocarditis you missed. Yes.
infective. No, I said infective endocarditis
said?
and
Okay.
rheumatoid
He
heart
said
disease.
yes,
Okay.
and you said rheumatic and ischemic heart
Heart
disease
disease.
and
Ischemic,
endocrine
yeah.
causes, you know,
Congenital.
endocrine causes,
Endocrine causes, I don't know which endocrine causes.
hyperthyroidism. Can cause,
Hyperthyroidism.
yes, can cause
MR.
mitral, yes.
You're
Problem.
sure?
Yes.
I did not listen before.
It's not common.
Hyperthyroidism
Yes,
can
not
cause heart
common
failure.
cause.
Heart failure, but not MR, I think.
It can
It
cause
can
AF
cause high
and it can
volume
cause
cardiac failure.
Yes,
yes,
AF
it can cause
can
AF
be,
and
but
endo.
valvular.
Yes.
Mm-mm.
But that is AF. This is different issue. That is not related with the mitral stenosis or MR. In the hyperthyroidism, there is a high volume cardiac output failure happen. I mean, your body need more blood. That times it's more pumping. High volume heart failure. That is, I think, not valvular heart disease.
But also MR can be with
That is for
long
heart failure,
standing,
yes.
yeah, with long standing. Okay, and also some type of mitral lesion with systemic lupus.
Prolapse.
You mentioned it.
Prolapse, yes.
Yes,
Connective tissue disease.
yes. That is Limban-Sachs syndrome, I think, or something. Limban-Sachs syndrome, maybe.
Libman-Sack, yeah,
Libman.
Libman.
Yes,
Yes.
Libman-Sachs
Excellent,
syndrome.
doctor.
That
Okay,
is for
thank
the
you.
SLE related.
Yeah.
And your second question is when we will do mitral valve
And
replacement. First
the
of
other
all, any
cause you
patient is
can
symptom-
mention in all valve other valve lesion like aortic stenosis by time can be mitral regurgitation.
Yes.
Like that, yes. Other valve lesion can cause the mitral lesion.
Okay, one comment written here, mitral valve prolapse. Yes, this is very important. Mitral valve prolapse. Okay,
Prolapse,
so
yes.
one,
As
yes, your another
association
question
with,
is,
we didn't
yes,
mention, sorry, the
your
association
another
of
question
mitral
is
valve.
when we'll go for replacement. First of all, each patient is any symptomatic like chest pain, palpitation, picture of the heart failure, any complication develop, patient is symptomatic, breathlessness, like that. And if we go for the mitral stenosis, like intensity of the murmur is increased, with there is a first heart sound became soft in case of mitral stenosis. I mean, that time we think it can be calcified valve, and the patient is not, if not fit for surgery, I mean replacement, we can go mitral valve commissurotomy, I mean valvotomy. If patient is symptomatic and complicated, we should go for replacement.
Thank you, Dr. Tamrin. Really excellent. MashaAllah.
Okay. One doctor asked, what is the cause of the MS? First,
Infective
second, third.
endocarditis as
Third
a
is,
cause of surgery or indication of surgery.
yes, infective endocarditis. Yes. Yes. Any
Okay.
vegetation, any adhesion, any stiff valve, I mean calcified, highly calcified valve. So
Yeah,
and
resistant to the
complicated
treatment of
to go
infective
for.
endocarditis. Yes, there is
Yes,
selected
maximal treatment.
selected criteria for infective endocarditis to be transplant to be replaced. Like aortic
Infective
clot abscess,
endocarditis,
but this is not
usually
yeah.
surgical indication is if there is a new valvular regurgitation, feature of the heart failure, large vegetation thrombus, and maximum medical therapy when failed,
Exactly.
and
Yeah,
when you are using antibiotic, recurrent
resistant.
feature of the
Yeah.
infection, resistant to the antibiotic, you need to go
Yes, exactly.
for surgical option.
Yeah. So
And
let's count
another
the
important
causes.
point. Another important point I need to add that if clicking sound reducing, that means valve may be clotted or thrombus can be formed. I mean, metallic click should be loud. If loud, that means it's well working. When its
Mhm.
sound is reduced or unable to that time listen, that time it may be clot or vegetation formation. And another thing is in the aortic valve, supposed to be ejection systolic murmur will be normal if patient is not complicated. Same thing for mitral valve, mitral stenosis murmur can be normal. But if any regurgitation murmur means it's a feature of the valvular leakage or valve failure.
Yes. Just want to add, thank you, Dr. Anvir. I want to add the causes of mitral valve prolapse. So it could be
Mhm,
in females, and
mhm,
it could be association with other connective tissue disease or collagen disease like
mhm,
Ehlers-Danlos, Marfan,
mhm,
and it could be association with autosomal dominant polycystic kidney disease. These
mhm,
things, yeah, it make the answer like completed. If
mhm,
you want to add the causes of mitral valve
mhm.
prolapse,
Mitral valve prolapse.
okay?
We can tell mitral valve
Yeah,
prolapse, but if you want to tell what are the other
yeah,
cause
yeah.
of mitral valve
If he
prolapse,
asked, yeah,
like it
exactly.
will be
I'm
taking more
just
time.
giving, yeah, I'm giving
Yes,
as more information, but it's enough to say mitral
yes,
valve
yes.
prolapse. It's enough to say congenital
Prolapse, yes.
cause because congenital means congenital, nothing else. But don't
Yes,
forget
yes.
to put at the top of them, as you said, rheumatic heart disease,
Mhm.
particularly in the developing countries.
Three times
But in
rheumatic, after that any other disease.
yeah, yeah, but you have to mention rheumatic. After that, you can mention whatever the cause or the type of your disease valve. Okay, thank you, Dr. Tavir. Sorry, Dr. Awatif, suppose you have to
Welcome.
comment, but we make you late. Can you comment now about the case? Any finding, any missing point, any point you want to add?
Yes, yes, I have comments to Dr. Tanvir. When I asked it about differential, the examiner then need the differential, all the differential, at least 2 to 3, because the time will go and he did not finish his answers. Also, I asked it about the management. Yes, the treatment. Just to complete, he did well actually, mashallah, yani. But this just like some advices, inshallah, for better luck in the exam, inshallah. In the treatment, just warfarin and complete the sentence. Complete, I mean the answers, because there then will be no any time to for the examiner even to help the candidate. Yes, this is my comment.
So warfarin,
Okay,
you mean
thank
should
you.
معلش
they
يا دكتور
answer?
عواطف معلش
Yes,
يا دكتور عواطف عايز اسال بس حضرتك
especially
بتقولي ان خلاص العيان اوريدي انت شخصتي ان هو ماترال فالف ريبليسمنت ديفيشن
Dr.
دايجنوز
Mahi,
ايه بقى كوز
In English, please.
دكتور عواطف
yes.
you already diagnosed this patient is mitral valve replacement because S1 is metallic خلاص now it is clear cut this is mitral valve replacement why you ask the differential diagnosis of what it is already diagnosed and it is only one
The
diagnosis
scar.
Differential diagnosis of the scar.
of the scar in general or in this
Yes.
In
case
heart, mid-sternotomy. They will ask about
No,
cardiac
just a
case.
minute. Just a
in
minute.
this
I
case
have to add
in this
one
case
point.
only in this case only or in general
In
No,
any
no.
cardiac case.
Tell him about this case, please.
Because you already found this patient has metallic click, خلاص, no. But if there is no metallic click, so now maybe this is cabbage, maybe heart transplantation, maybe
Yeah,
prosthetic
this
valve.
is
Like,
yes, this is the way how to answer this question exactly.
I
okay.
didn't
I
get
just need to be little clear. Okay, Dr. Mahi and Dr. Atif. So if there is a what if examiner asks what is the differential of that scar mark,
yes about
just
potential. Yeah, just
that time we can
to
tell. Yes, that time
yes,
we can tell metallic
health,
valve
yes,
replacement, biological valve replacement, cardiac transplantation, or thymectomy like that. But if asking what is this metallic
yes,
click, so I already said that
yes,
is the metallic click with the first person. So it's obviously mitral. It's not going with that aortic, not going with the biological valve. But if examiner asks, okay, when a click can happen, that time I can tell yes, aortic valve replacement click can happen like that.
this is the top differential.
I think this is the answer. Yes, this is I think. So if you ask me that click, I can tell metallic aortic or double. And
Yes,
if you ask me about the midline sternotomy mark, what are the other causes? That time I can tell cardiac transplantation, thymectomy, aortic, mitral, or biological valve. And your advice is nice that I need to tell, we need to mention, we need to continue the warfarin according to the regular checkup, that INR, and also we need to do, if there is no complication, we need to 6 monthly we need to do that echocardiography.
I wanted to ask you one question. Dr. Awad,
yes,
if you told us that echo every 1 year and INR every 1 month for any patient with metallic valve,
yes, he must do the INR. Yes, he mentioned that with the treatment. Yes,
why echo every year? Why echo for what?
Echo we need to do every 6 monthly to monitor that
Why?
valve function properly.
No,
We need to
no.
see any complication, any.
No.
Okay, Dr.
This is
Mahi, you have
routine. This is
objection about
routine.
Dr. Yahya
You
Mahi.
have to do.
Yes, you have objection about the duration or about the echo itself, Dr. Mahi.
We do echo one time only after the operation to know the baseline gradient of the valve. Then
Okay,
خلصنا.
later on,
There
no
is
follow up.
no
No,
follow-up.
but in past tests, they mention in past tests we have to do frequently, regular manner, follow up echo for any transplanted or sorry for any replaced valve. I
This
don't
is
know.
my practical experience and
Yes,
also
yeah.
my study experience. This is both because I have a direct valve replacement patient, and when I'm meeting, all the time I'm asking, "What about your INR?" All the time I am asking. After
No.
salam alaikum,
He's
what is
asking
your
about
INR?
echo, not INR.
No,
Echo,
no,
echo.
that is I'm asking. That is I'm asking the patient, are you doing regularly INR? Are you checking regularly echo? He is always telling yes, every 6 months I'm going for echo, and every month I'm going for INR. So I have one friend like that. So I'm always talking with him like that way. And
Okay.
also due to a study purpose, we know. And even patient is coming with the complication. That time you should not wait for 6 months. That time you have to come anytime when complication, you need to do echocardiography.
Dr. Mahi, you have a background as cardiology or
As cardiology, yes. I have American Board of Echocardiography.
okay.
Echocardiography is not indicated for this patient, but okay, we do this for MRCP. We can finish this, but scientifically not indicated. Only baseline and every 5 years, or I have a complication.
Okay. So you mean you have to do baseline post replacement, then according to the need or PRN if the patient have
Yes, in
developed
American,
anything.
it is like that because here in Saudi we follow the American, but UK different.
Okay.
Greatly,
Perfect.
yes.
Yes. So we have to know the European guidelines, NHS, and the American. Of course, there is big difference. By the way, not only the cardio, even the neuro, they are different. You remember the indication of endarterectomy in European and in USA, in American. There is a big difference. In European, they are doing endarterectomy with I think 75
More than
stenosis.
50. More than 50 in the
50?
American, but
Okay.
in the
Yeah,
more
and
than
the
50
American
in the
50, but
American, but in the Europe, more than
yeah,
70.
75 in the Europe. Yeah, 75.
Yes.
Yeah, so there is major differences, but don't please follow the American. You are in a European exam. UK rules and MRCP, they are following NHS and European guidelines. So they are doing it in regular manner, annually or yearly. This is mentioned in bus test. In any replaced valve, Dr. Mahi. Okay?
Okay, sir. No problem. I also
Okay.
heard that you said, Dr. Awatif said, this valve, metallic valve is durable for 15 years. Is that right?
Yes, this is what also written. Tell us about your opinion.
It is lifelong. Metallic valve is lifelong.
Yeah, supposed to be
Not
lifelong, but they are
the
doing also
bioprosthetic valve. The bioprosthetic valve is
5 years.
durable for 10 to 15 years. But metallic valve is lifelong as long as no gradient,
As long
no
as,
venous
yes.
coagulation, no infective endocarditis.
Actually,
But
that doctor, I think, shared his exam experience. Yes, we know that metallic valve is lifelong. Usually, we need to continue working lifelong. And bioprosthetic valve usually 10 to 15 years because it can be calcified. But I think this question asked in the exam. That's why she asked.
yeah,
So that
I
time we
I
can
think
tell
also it
yes.
was written. It
Yeah.
was written also in the
Okay.
differences.
It's
But
supposed to be lifelong.
the sentence that the life expectancy is equal in the mechanical and prosthetic and biological. This is the life expectancy is equal.
No, it is not right. This is not right at all. No
No, I
calcification
think
for
not
the
life
metallic valve.
expectancy. No. Not
It
life
is not the
expectancy is
life
not
of the valve,
safe.
not the life of the valve. It is the life of the
Uh,
patient.
The
Patient,
patient, you mean?
patient life,
Yeah,
patient life.
Yeah.
Okay, patient life. That is, we don't know, but usually more durable is mechanical valve. That's why mechanical
yeah.
valve is suggesting.
Okay,
Yeah.
durable. As Dr. Mahi said, he want to say lifelong, right, Dr. Mahi? It's not 15 years.
Yes, sir.
See,
Yes,
it's supposed to be lifelong.
metallic valve is durable for life.
Lifelong,
They
yes,
asked
but
me this question in
Except,
exam ready,
except
and I,
if
and
developed complication. If
I,
developed
I, it's
complication,
first time I hear it in exam. But when I search, it is from 15 to 20. And
So
there is
there
also
is some
life.
diplomatic answer. Diplomatic answer. Life, it will be okay, lifelong. But if there is infective endocarditis, valve damage, what you will do? You need to go for replacement like that. So maybe after 10 to 15 years, maybe anything can happen. We don't know. So if examiner like asking like that, we can tell as a diplomatic way, like after 10 to 15 years,
for
maybe need to replace.
really, I have a diplomatic answer, so I can say it's longer than the prosthetic valve. That's it. The metallic valve.
I replied him. I found the patient live live normally with this valve for more than 10 and 20 years.
Yeah,
Just this because I don't know really in the exam.
yeah,
But when I
and
search, it is
yes,
the median life for any mechanical valve. It's about from 15 to 20. So uh, if you know the answer, you can reply because it's written
yes,
in text already.
yes. Okay, so let's say 15 to 20 years. Uh, any other question, Dr. Awad? Any comment else before going to the next case? Dr. Tanvir, you have prepared any case?
Yes, the last comment that in the treatment.
Yes,
Also,
please.
just remember the non-pharma like advices like if the cardiac rehabilitation program if there is need, and
Perfect.
also the cardiac risk
Yes,
factor.
Yes,
Patient
100% agree.
education, counseling,
Yeah,
smoking
100%.
stop, vaccination, cardiac
Ex
rehabilitation therapy, specialist nurse under the monitoring by cardiologists.
and indication of
Like that.
prophylactic antibiotics for infective endocarditis. Let's
Yeah.
arrange the order for investigation, Dr. Tanvir. I know you give the whole investigation, but again, let's do it in our regular and systematic manner. General, specific bedside, and invasive, non-invasive imaging and invasive tests. Let's do it in this patient, okay? Starting by general. What's important general investigation you should do here? The CBC, of course, to rule out anemia. INR to check for the coagulability of the patient, either normal or target, subtherapeutic, supratherapeutic. I think this is the most important liver function test. If the patient is, for example, in the stage, so there is some bias about the INR, or kidney function. Also, if you want to add some medication for the patient, like anti-failure medication. This is for the general. Specific investigation here is very important to mention BMB and troponin, especially those patients present with short of breath or presented with chest pain. You have to mention both investigation as a specific. Why? The patient might be in failure and you have to start him on anti-failure medication, or the valve is non-functioning. The troponin, because if you suspect STEMI or non-STEMI or acute coronary syndrome for any reason. So again, you have to refer the patient to cardiologist and to manage accordingly. This is regarding the specific. The bedside test, as Dr. Tanvir said, ECG, echo, urine dipstick for any proteinuria or hematuria associated. But the most important is ECG and echo. And here you can mention the bedside echo as transthoracic echo. The imaging, again, the echo, the tool of choice to diagnose the patient, to check the function of the murmur and any of the murmur or any complication or associated valvular heart disease. And you have to mention the cardiac function, systolic and diastolic. This is the aim of any echo for any patient. The function, systolic or diastolic, valvular, rule out other valvular heart disease, and particularly this patient to check for his murmur functioning or failure or complication, thrombosis, or any association or complication. Then the last is the invasive. What do you think invasive test we can do here in this patient particularly?
Cardiac
The,
catheterization, you ruled out.
yes,
Pulmonary
perfect. If
hypertension.
right catheterization, if there is suspicion of pulmonary hypertension, to check for right side pressure, or TEE, transesophageal echo, it's one of the invasive, of course, if you want to check for any vegetation, if you suspect it, of course. And coronary angiogram, if you have any acute coronary syndrome or chronic coronary syndrome association. Okay. The lipid profile, also one of the general you can add if you suspect acute coronary syndrome to rule out atherosclerosis.
That is fasting blood sugar and lipid profile you can do for any
Yes,
cardiac cases,
perfect.
just as
Yes,
the
just
metabolic syndrome purpose.
perfect.
I want to add like that regarding the chest X-ray. Why we want to do chest X-ray? We
Yes,
need to see any
perfect.
cardiomegaly, any
Perfect.
feature of the pulmonary congestion, or prominent pulmonary vasculature, which can indicate pulmonary hypertension, or any
Perfect.
calcified valve. In the ECG, we need to check any feature of the atrial fibrillation or left ventricular hypertrophy, like that, or
Yes,
any P pulmonale, P mitrale. In the echo, we need to check, confirm our diagnosis. Is there any other
exactly.
valvular disease, any adhesion, thrombus, calcification, or feature of the infective endocarditis, and also ejection fraction and left ventricular or right ventricular diastolic diameter, systolic diameter, we need to check.
Perfect. So if you make it in this systematic way, you will get full mark. Believe me, they will ask you in every category, and if you give one example for every category related to the case, you will get good. You will get or you will gain good mark because you mentioned here the specific as BMB and troponin. It's very important to mention BMB. If you miss the specific, you will miss it, and it's important for such patient if he present with you short of breath. Okay. Uh, let's move to the next scenario. Dr. Tanvir, you prepared the case?
معلش يا دكتور باسم عايز أسألك سؤال لو سمحت.
Yes, of course, Dr. Mah.
Can some patients atrial fibrillation and uncontrolled, the patient has tachycardia irregular, and this patient has metallic click, and you cannot see timing of this sound is metallic S1 or metallic S2
Yes.
to say this is aorta or mitral, and
Okay.
sometimes I cannot put my hand on the carotid and
Carotid.
see timing. I cannot do two actions at the same time.
Mhm.
So how I can differentiate? While I was preparing before, I was confused how to say this is mitral or aortic. Sometimes I can hear that is one of them is a native sound, and the other one is metallic. But I'm not sure which
You are
one
not
is
sure.
which one
Okay, I will
is.
make it a clue, okay, for you and for others. If you have AF, 99% this is mitral. If you have AF with click sound, this is mitral. Another clue, one also of the doctor cardiologist said to me this clue. Most of the mitral patient are females, like chromatic heart, but not a rule. Okay, most of them, but not as a must. Again, if you have AF, so this is mitral. If you have female, mostly this is mitral. And if you have male, mostly this is aortic, either due to sclerosis, I mean replacement due to the cause or the pathology as sclerosis or stenosis or whatever. And if you have a murmur, it will be your clue. If you have a murmur, you will hear the click sound. If the click sound come first, then the murmur, this is metallic. If the murmur coming this, then the clicky sound, this is aortic. So you will hear tick, sh, this is mitral, tick, sh, tick, sh, or sh, tick, sh, tick. This is aortic. This is the main difference between both of them. Don't confuse yourself. Try to auscultate and to focus while auscultating. If you are confused while putting your hand on the carotid, put it as only like
I make it on radial, and no one comment on that, even in
yeah,
feedback.
just
Because
put it
really
like you
also
are.
I am with carotid, I am not very well to
I agree.
concentrate, so I use the radial.
By the way, in the AF, you cannot judge because it's irregular already. But please, you have to mention the AF. Dr. Tanvir, I think he missed the AF in the presentation. He didn't say this is irregularity. He said pallor, he said everything, but he forgot to
I said
mention the pulse.
irregular pulse,
You said?
irregular
Okay.
pulse with that
Okay.
feature of the anemia.
Okay.
One thing I think that yes, this is sometimes confusing which it is aortic or mitral, because the double valve replacement supposed to be double click, but it's metallic click. If it's going with the carotid pulse, we need to think about the mitral, and it's not going aortic. But as Dr. Autis said, that taking radial, because sometimes not understanding. And Dr. Basim has said, if atrial fibrillation supposed to be, it will go for mitral valve. And also, if there is a low volume pulse, regular, we can think it's aortic. And also another thing is when you move your stato and when you feel that murmur sound, any murmur or heart sound is increasing when you taking in the apex area. So we can think it's probably mitral. And when we found that it's more going to the aortic area, I mean systolic murmur or the click sound is increasing when you're shifting to the aortic area. So we can think is the aortic, because I applied these rules in some physical examination and most of the time it's became correct.
Yeah. Perfect. Okay. For those who's maybe beginner, I'm sure it will help just to repeat the steps of examination. I try to be in a quick manner until Dr. Tanvir will prepare or write the case. So let's start from the end of the bed as usual. Always introduce yourself. Any pain, any chest discomfort, let me know. Then stand at the end of the bed. Any surrounding. And while you are standing at the end of the bed, check for the leg edema. Before examining, ask for any pain. At the same time, expose the whole leg. You might have harvesting scar. If you miss, you will miss the case. Check until the knee. Okay, just expose until the knee and try to check the medial side of the leg for any harvesting scar. It will be longitudinal scar, slim and thin scar. You finish the leg, you will go to the hand. Extend your hand, please. Check for any clubbing for a subacute infective endocarditis or the infective endocarditis, stigmata, Janeway lesion, osseous nodules, or the splinter hemorrhage. Then the front or the palm for any pallor. The pulse, count quickly in 10 seconds, then times in 6. And please don't forget to check for the equality, both hands and regularity. Offer the radiofemoral delay. Usually they are saying skip. Then do the collapsibility. Raise the arm. Before raising the arm, ask if any pain in your arm. And if you feel the collapsibility, this is mostly regurg or hyperdynamic circulation. Then to the face, please raise your eyelid up and down for pallor and anemia. The mouth for hygiene is very important. Dental hygiene in such patient, it's a clue for infective endocarditis suspicion if you have a case of suspected for infective endocarditis. Then you will ask for the patient, can I push over your tummy for, of course, in the 45 degree. Any tummy pain for raised GVP, you finish. Now you go to the examination of the chest. Expose the chest, please. Any scar around. You can notice anything else. But mainly, you have to focus on the mid-sternotomy scar. If you have hair, please do it in focus manner. Focus more and more. Some scars, professional doctors, you cannot see it. You have to expose the mid-sternotomy area to find the scar. Then you try to palpate the apex by your hand and to count where is the apex exactly. Is it in the mid-clavicular or displaced? And most of the patient with regurg, the apex might be displaced outward to the clavicle, away from the mid-clavicular line to the axillary line. Then now the time for examining for the parasternal heave for right side hypertension, parasternal heave by the palm, base of the palm. Then for second, for the pulmonary area for pulmonary thrill or aortic area for pulmonary. This is by palpation or for palpation. Then the last auscultation. Start by the diaphragm, hearing the apex for mitral regurg murmur. It's clear murmur, you will hear it pansystolic. Started from the first, covering the most of the systolic period. Then you will go with the diaphragm to the axilla. If there is propagation, this is mainly pansystolic murmur for mitral regurg. If not, make the bell over the apex and ask the patient to turn to the left side to auscultate for any murmur. Mid-diastolic murmur means there is mitral stenosis. If you suspect or you have metallic sound, so this is mitral replaced. You can also hear murmur if the murmur there means this, the valve is not functioning. If you have murmur while doing auscultation over the apex, so this is mitral regurg complicated the mitral replacement. Then you auscultate parasternal heave for the tricuspid regurg. If you suspect tricuspid regurg, you will have raised GVP, which will be pulsatile. And the murmur over the tricuspid will increase with inspiration. But the other murmur for the mitral and for the aortic will be accentuated or increase with expiration. You have to mention this while presenting the patient. Then the pulmonary area for pulmonary loud B2 or loud B2, or you can hear also systolic murmur over the pulmonary. This is for pulmonary hypertension or pulmonary stenosis. The last is aortic. While semi-sitting, you can hear a murmur which is going to the carotid, radiated to the carotid, and increase with expiration. And you can hear the aortic stenosis murmur, which is ejection systolic murmur all over the pericardium. You can hear it even over the apex radiated to the axilla. If the significant stenosis, you can hear this murmur. It was my case in the lung, and I hear the murmur. I was about to say this is mitral murmur, but the murmur will be more accentuated over the aortic area, first aortic area, and it will be more radiated you can hear it over the carotid with the bell. The last auscultation for the heart sound or the murmur or the aortic area over the second aortic area in the left third intercostal space. After putting the patient in sitting position forward, you ask him to take deep breath in and out and hold. If there is murmur, this is aortic regurg. And the aortic regurg, you will have patient with all peripheral signs of aortic regurg. Decassé and pulsatile carotid, pulsatile nail. It will be evidenced also by regurg pulse volume or high pulse volume, okay, in the radial area. The last auscultation for the back, for the bibasal crackles, to auscultate if there is heart failure sign, and the sacral edema for right side heart failure. When you present, you have to present your finding peripherally, going to the central, and at the end, please add 3 signs. If it is negative, you have to mention them. I couldn't appreciate signs of heart failure. I couldn't appreciate signs of infective endocarditis. I couldn't appreciate signs of pulmonary hypertension. Of course, after presenting your case. If you have any of them, you will present them while doing presentation. For example, if you have pulmonary hypertension sign, you will say, I can appreciate parasternal heave. I can hear loud P2, and this is presenting pulmonary hypertension. But at the end, you will deny the other negative, like I couldn't appreciate signs of infective endocarditis, I couldn't appreciate signs of heart failure. I hope it's clear. And we can move now to the next scenario. Dr. Tanvir, you prepared? Any case.
Yes, I will share. Yes, that's the respiratory
Yes, okay.
system. Dr. Atif, ready?
Dr. Awat, if you're here?
Yes, there. Yes, ماشي شبكة.
Yes, okay.
Yeah, I will share the picture. You just so examine this lady respiratory system. I'll share picture in the group. Huh?
Cannot give you another cardiac case, Dr. Tanvir?
As you, no problem.
Yeah, better to make it in one
I
day.
want to give actually a respiratory case, but if you want cardiac, it's okay, no problem.
Respiratory, let's make it on Thursday. I want to make the session
Okay,
for
no.
clear for cardiac, for
Okay,
example.
no problem, no problem. So I'll give the cardiac case.
Yes, please. Thank you.
Okay. I prepared
No
respiratory
problem.
now
Take your
immediately
time. I'll
cardiac.
read the comment.
No,
I'll
no,
read the
no, no
comment.
problem. No problem. I'll share. Okay, so that is 30 years old male. Please examine his cardiac system.
Okay. Start.
Yes, you can start.
Hello. Sorry. Hello. I am Dr. Ahmed. One of the candidates in the exam today. I will examine you. If you feel any pain or discomfort, let me know. Is it okay?
It's okay, doctor.
Okay, we'll come back. Then I will inspect the surrounding the patient. If there is anything surrounding the patient, like your skin, for example, or any other thing.
No, in the bedside, nothing.
Okay, then I will go to the patient and examine the patient from up to down. Anything abnormal. I will start from the hand. There is any clubbing.
No clubbing.
There is any splinter hemorrhage.
No splinter hemorrhage.
Can you turn your hand to the other side? Any genuine lesions,
No granulation.
cyanosis,
No sinus.
Osler nodes.
No slumber.
Then I will check the pulse. What is the pulse exactly? And if it's regular, irregular, any problem in the volume, in the character.
I'll just tell you that pulse looks like something irregular, something jerky, like that. Not normal rhythm.
Mhm. Is it synchronized? If there is any radiofemoral delay,
No radio radial, no radio femoral delay.
collapse in pulse.
Yes. No collapsing pulse. Normal.
Yes, and then I will go up to check the any jaundice, any color.
No jaundice, no pallor.
I will check the mouse to
What you
any.
check in the mouth?
I will check in the mouse for the tongue, and also if there is any cyanosis, intracyanosis.
No sinuses.
Then I will check the GBP trace.
Not trace gravity.
Um, anything in the chest like scar or any deformity.
No deformity, no scar.
Then I will check the leg. There's any swelling in the leg or any tenderness,
No, no leg swelling or tenderness.
peripheral pulse,
Sorry, what?
peripheral pulse.
Peripheral pulse? Peripheral pulse normal.
Then I'll come back to the chest. Then I will try to localize the pulse. I mean the apex. If it is in place or displaced.
Apex looks like little outward depressed.
Okay. Which the closest is?
Sorry, it's
Which
like slightly downward, slightly outward from that normal position.
normal position outward. Okay. Then I will check the character.
You found something like thrusting, you know that something double thrusting, like not like regular. When you feel not looks like something hyperactive.
Yes, any throw.
Sorry,
Any throw.
I mean something hyperactive, like something bounding, apex beat, something like hyperactive like that, thrusting like that.
Yes. Can you turn to the left side, please? I will check the murmur. There's any murmur or any click.
Yes. What you said that patient when you turn,
Can you turn to the left side, please?
not tell any other thing. Please hold your breath.
I didn't get you.
Please hold your breath, please.
Hold your breath. Okay. Thank you.
Okay. By holding, you will not found any mitral stenosis murmur.
Yes. Then I'll ask the patient to come back. I will check for any thrill in this area.
Thrill.
Yes.
You can found there is a thrill in the left parasternal area.
Yes. Okay. Then I will check if there is any thrill to the other area in the tricuspid.
Other area means which area?
I mean tricuspid, if there is pulmonary and aortic area.
Okay, you found there is a precordial murmur in the whole chest, but mainly left sternal area more.
Mainly where?
In the whole precordium, you will listen the murmur, but mainly in the left parasternal area more you listen.
Left peristernal here. What is this murmur?
It looks like systolic murmur.
Systolic murmur.
Yes.
Okay. Is it change with taking deep breath? I mean, so more with the inspiration or expiration?
Inspiration or expiration, it's not like changing.
Not changing. Okay. Is it related to the axilla?
Is it? Yes, you can found there is another systolic murmur going to the axilla.
Is it same murmur?
It's not same, little different.
Is that one that is the axilla is uh, okay? Is it a systolic murmur also or diastolic murmur?
Yes.
Okay. I will put the stethoscope on the all the area, valve area, even the pulmonary and aortic and the other murmur.
Yes, I said already that whole precordium there is a murmur, but mainly the left parasternal area more.
Uh-huh. Okay, then I will ask the patient to sit. I will ask the patient to lean forward. I will put this stethoscope in the second aortic area of
What
any diastolic murmur.
what you said?
I will put this stethoscope in the second aortic area. I'll ask the patient to take
In the sitting position. In the sitting
in,
position.
yes.
Yes.
I'll ask the patient.
Yes, that is no, not like early diastolic murmur. I mean no air murmur.
Okay. Okay, then I will I'll check for carotid artery. I will
No carotid rule.
yes, this is called in the back, in the pulmonary, no, sorry, in the bypassal area, and also if there is any pain, let me know. I will check to
No pain.
mitral edema. Thank you. I will
Okay,
follow the patient.
time is up. Yes, thank you, Dr. Atif. Now the examiner question, Dr. Tanvir, please.
Okay, present your finding, please.
On examination of the patient, patient is lying on 45 degree bed. Pulse rate is I didn't check it, but it was
80 beat, like 80, 90 beat, no problem. Pulse rate 90 beat.
69. Yes, it's 69. Uh, uh, Irregular in character. Yes. Apex feet in the fifth intercostal space, laterally displaced. There is murmur. This murmur is systolic murmur on all over the precordium, louder on the left side of the sternum, and there is other murmur, not a change with respiratory cycle. There is another murmur in the another systolic murmur in the axilla. Apart from that, the heart sounds are audible. So my summary of my finding, systolic murmur for differential.
What your differential?
My top differential, this could be VSD, ventricular septal defect. Yes, could be also mitral regurg.
What are the murmur you get in the whole precordium, but mainly in the left lower sternal area?
This is
Uh,
common with ventricular septal defect, and that one in the
Sorry?
axilla with mitral
What you
regurg.
said? What you said for this?
VSD.
Okay. And what are your other differential?
My other differential is mitral regurg.
Okay, mitral regurg for second murmur, but I am asking that for what are the other different of the VSD murmur? You said VSD. What are the other
Yes,
differential there?
can be differential also can be tricuspid regurg. Yes,
Okay. Okay. So how will investigate this case?
I will do basic investigation. Apart from that, I will do cardiac workup to confirm the finding. I will do just X-ray, ECG, and echo. I will do investigation for the complication if there is.
Okay.
Yes.
So yes, you think this is the VSD murmur, but
Yes.
if it's you feel this is a like ejection systolic murmur, the same character, same everything same, but ejection systolic. What you think this murmur?
Then I will think that this murmur could be ASD murmur.
Sorry, what?
ASD, atrial septal defects.
But this is not typical location for SD. Okay, what are your other DD?
Yes, in view of that, this murmur is not changing with the respiratory cycle, so I will suspect the ASD. Also can be aortic stenosis, but this is not the exact area for it. Can be also pulmonary stenosis.
Okay, but young person with something jerky, irregularity, with apex beat going to outward, downward, with you found MR and all the area systolic murmur, but mainly in the left lower pasternal area. What do you think? I just give a very nice clue. Young person, think young person.
Yes, could be a hyperatrophic cardiomyopathy. Yes, in view of the age
Yes,
of the patient.
yes. You should think first this one. Like I said, jerky, thrusting pulse. In the apex beat also like thrusting, like double. If I tell double, you will easily catch. That's why I said something thrusting, hyperactive, double like that. And it's also if long time hypertrophy HOCM, so it can also related with the heart failure. Patient can present also with the feature of the MR. So this is like HOCM with MR. But if you go for other DD for HOCM, it can be aortic stenosis, but not like that. In the aortic stenosis supposed to be more in the aortic area. I mean, right second intercostal space area more, and that time usually in the AF the pulse is regular and low volume, but here it's not regular or low volume. This is something like thrusting, irregular jerky pulse with apex beat is thrusting outward, downward, and also patient you can found in the whole precordial murmur, but more in the left lower sternal area and younger age. So to come, we should think first, and against that, yes. And what are the other cause of the ejection systolic murmur? That time you can tell yes, aortic sclerosis, pulmonary stenosis, or ESD. But against there is a point, and also the second murmur going to the apex to the left axilla, and which is another systolic, looks like pansystolic, like blowing murmur. So pansystolic is blowing, and aortic stenosis murmur is like harsh murmur, descendo descendo. So it's a case of the HOCM associated with the MR.
Mhm.
Okay, so how will treat this case?
I will counsel the patient about the condition. I will give the patient some advices to avoid any risk, cardiac risk factor, like smoking and alcohol, moderation if he's a smoker, and also cardiac rehabilitation program if there is need. I will treat put the patient according to the investigation results. Firstly, I will treat if there is any symptom of heart failure, to treat it, treat if there is any complication, and according to the investigation and assessment, if there is any need for surgery, then we can do surgery.
Okay, my last question. If you want to give one advice to the patient, which advice you will give, and tell the three treatment of the HOCM.
One advice to the patient.
One advice if you want to need to tell, what one advice
Yes,
you will give?
to avoid any vigorous exercise.
Very nice. To avoid any type of the vigorous exercise. And
Yes.
what are the treatment in the three treatment if you want to give?
The treatment? Yes, I will
Yes,
treat
for
the
HOCM.
patient by prophylactic ICP.
Okay. What
Yes.
are the? You will initially
Yes,
you have to give beta blocker. Beta blocker, then prophylactic ICD. If patient is still symptomatic like that, non-pharmacological, yes, we already said non-pharmacological, that is finished. So medical treatment, beta blocker, ICD
yes,
pacemaker. You can go for surgical myomectomy maybe need. If feature of the infective endocarditis, you need to treat for infective endocarditis. If there is a
yes,
heart failure, or
yes,
you have to treat for heart failure, and also pacemaker. If you think that there's heart block or something, you have to go for pacemaker. So like that.
yes.
Thank you, Dr. Ratis. Is there any
Thank
other question for anybody?
you.
Yes, I will add one more question. Please not read the chat box, Dr. Awatif. What other non-pharmacological you have to do here in this patient?
المشكلة قريته. لما بديت الكومنت قريته.
Okay. Okay. So family screening is important in such patient,
It's very
especially if,
important point. Yes.
okay, especially if what? This is the question now.
Especially if there is any history of sudden death.
Perfect.
Yes.
Perfect. Yes. If there is a family history of cardiac death, you have to screen other patients or other family members. Okay. And the mode of inheritance of HOCM?
It is autosomal dominant.
Perfect. What are the component of HOCM?
Component of HOCM.
Yeah.
Sorry. What do you mean by component clinically?
Mr. Sam Ash.
Sorry.
Mr. Sam Ash. You know this abbreviation?
No, I don't know.
Mr. Samish for eco finding.
Yeah, eco
Yes,
finding. Yes, component of eco finding.
yes.
Yes.
I have no idea about it. You can explain it.
So what you can find in echo in such patients?
Yes, I left ventricular hypertrophy. and narrowing of the aortic valve.
It's not by what you explained.
Mhm.
Okay.
Mhm.
What exactly the area will be thickened? Which part of the heart will be thickened?
Myocardium.
Yes, particularly what?
I don't know.
Septal.
Yes.
Okay, and what area of the aortic will be narrowed or stenotic? Which area particularly, or which?
The area below the valve.
So subaortic, right?
Sorry.
Subaortic,
Below
subaortic
subaortic.
stenosis.
Yes. Subaortic area. Yes.
Yes, okay. Any other options for the treatment apart from the medical and non-pharmacological? Any surgical option?
Yes, there is a prophylactic ICD, and also we can do surgery, myomectomy.
Perfect. So
What
either
is the
surgical.
indication of ICD?
Good, Dr. Arish. Yeah, answer this question, Dr. Awad. The indication of ICD.
The indication for ICD is the prophylactic for primary arrhythmia, like this HOCM, and also
Yes.
other arrhythmia, and also can be for treatment. Yes.
So, okay.
Uh,
Yes,
mm.
Dr. Aisha, go ahead. What else you want to ask?
Okay, first degree sudden death relative and thickness more than 30 millimeter and unexplained syncope or recent syncope. This
Can
is the
you repeat
indication
it
for
again, Dr.
implantation of ICD.
This is
Can you
actually
repeat?
poor prognosis. This is what are the marker of poor prognosis, like young patient, syncopal attack, history of the family history of the sudden cardiac death, and septal thickness more than 3 centimeter or 30 millimeter. These are actually called poor prognostic marker for the HOCM, and we need to give immediately ICD like that. But as a poor prognosis, this is.
Yes. Last question, Dr. Awatif.
Yes.
What are the ablation option you can offer?
Ablation option.
Yes.
Is it
Surgical
yes?
and
Is it?
there's
I don't know.
alcoholic, right? Alcohol ablation.
Alcohol.
Mainly surgical myomectomy, as you said.
Yes. Alcohol septal ablation. Yes.
Okay, for the finding of the echo, as I said, there is abbreviation called Mr. mnemonic, Mr. Sam Ash. So the MR for mitral regurg, you might have mitral regurg. You have also you might have systolic anterior motion of anterior leaflet of the mitral, which is SAM, SAM, Mr. Sam Ash, and asymmetric septal hypertrophy. Okay, remember this because they might ask you what are the finding of echo or echo finding in HOCM. Mitral regurg, anterior and or asymmetrical septal hypertrophy, and systolic anterior motion of anterior leaflet of mitral valve. I will send it to the.
There is also posterior roll motion. There is anterior septal motion problem and posterior roll of ventricle problem, like free wall movement.
All words
You
you mean,
you may
right?
mention only the like abnormal wall problem
Abnormal wall motion. Okay,
motion. Yes, yes.
but mainly the septal, right?
Yes, but if it is tricuspid regurg, the cause would be the abnormal ventricle movement.
Mitral regurg, you mean?
Mm-mm.
Not tricuspid, mitral.
Mitral, yes.
Perfect.
I just want to add some
Yes,
point
sure.
like
Go ahead.
yes, usually like any patient, just as a broad, as a like LCC pattern, like younger patient, they will come, they will tell when I'm going for football or when I'm playing, I'm sometimes feeling dizziness, my heart is beating more, sometimes I feel fainting. You can ask some family history from the family, hypertensive, diabetic, or maybe there is a cardiac disease or grandfather, father like that. And as you know that Jackie Pulse, you can found something and that apex beat double or thrusting apex beat, what we discussed. So when we go for ECG, echo and chest X-ray, in the chest X-ray, you can found that left atrium or left ventricular enlargement can be found. And also there is a feature of the heart failure can be found in the echocardiography. You will find that Mr. Samesh and Dr. Basim mentioned. And also in the ECG, you can find left ventricular hypertrophy or abnormal ST or T changes, I mean T inversion or STT like inversion or like that abnormality in the ST.
Yeah,
So
any
these are
ischemic change.
examiner, yes, ischemic. If patient examiner may ask what you found in the echo, ECG, or chest X-ray. So that time you can answer like that.
Yes, perfect. The last thing for the murmur, Dr. Awatif. What accentuate this murmur and what make it less, Dr. Awatif? By the way, this is the opposite of every and other murmurs.
Mhm. This is increasing by decreasing by squatting.
And increasing by
Other maneuver I don't remember.
Valsalva maneuver.
This is maneuver, yes.
Valsalva maneuver. Okay.
Yes.
But you cannot apply it in the exam, by the way. So, but if he asked you, you can answer in this way.
Exactly.
Okay. Perfect, Dr. Awatif and Dr.
You
Tanvir.
mentioned the complication or no?
Yes, arrhythmia. They mention as Dr. I think Tanvir mentioned arrhythmia, sudden cardiac death, syncope, and what else? Infective endocarditis, of
Any
course.
any any cardiac disease, complication usually for
Yes, exactly.
infective endocarditis,
Yes.
heart failure, pulmonary hypertension, arrhythmia. This is common for any
Yeah,
cardiac
For
disease.
yeah,
any,
you can
yeah.
mention any of
Almost
them.
common. And symptom what are common mainly chest pain, syncopal attack, dizziness, palpitation. But something different from case to case. Like MS patient or MR patient, usually they are more complaining about the palpitation because atrial fibrillation more associated. While in the AR patient may complain mainly about the feature of the heart failure. So almost all that similar, but something is more prominent in some disease, something is less prominent in some disease.
Yes. Always put the complication makes sense to relate it to the complaint and the diagnosis. For example, replace the valve. Of course, on the top you have to mention infective endocarditis. This is the most serious and most common, and you have to roll it out while doing examination and while doing investigation. We miss or we forgot to mention the blood culture for the previous case as a specific also. You can say it in the specific. Why specific? If you suspect infective endocarditis, you can send for two blood sets, blood culture, 12 hours apart. And once you suspect infective endocarditis, you have to start the antibiotics.
There is also
Okay?
12
question
hour apart or 1
contraindicated
hour
drugs.
apart?
Mhm.
1 hour apart or 12 hour apart?
12 hours. 12 hours.
12 hours.
Yes, it
Sure.
was. Yeah, sure. I reviewed many times, and we can
Mm.
ask also cardiologists. Anyone has a different opinion, he can. Yes, Dr. Aisha, what was your comment or question?
Other question, medication contraindicated in HOCM.
Yeah, perfect question, Dr. Awatif.
Medication contraindicated in the HOCM.
HOCM in HOCM.
And the
Yes.
AS aortic stenosis also we can add.
Yes, it
Mm.
can be also the same. Yes,
The diuretic and the
perfect,
vasodilator like nitrate.
perfect.
Excellent, yeah.
Okay.
Also nifedipine of one of calcium channel blockers, and they also can add the ACE
Inotropes.
inhibitors and so on. Yes, anything reduce the preload from the heart.
So any diuretics, any vasodilators, nitrate, and inotropes like dopamine. This is
Mm.
for yes, inotropes.
Yes. Yes.
Sorry.
Yes.
Okay,
Tropes and the digitalis, all this.
digoxin. Yes.
Mm.
Anything can decrease the reload or overload because this heart already dependent on the volume, and it makes the stenosis opened. If you reduce the amount, stenosis will be more signified, and the patient will be symptomatic more and more. Even he might be in arrhythmia and sudden cardiac death.
Okay, one doctor asked that what is the indication of the ICD? ICD is using for two purposes. One is prophylactic purpose like long QT syndrome,
Yes.
HOCM, Brugada, arrhythmogenic right ventricular dysplasia. These are the prophylactic. And treatment purpose like VT, non-sustained VT or
Non-sustained VT,
ventricular
yes.
fibrillation or VF. This is for the treatment purpose.
Or heart failure generally, yeah.
No, heart failure, ICD, yes, you as a supportive, like long QT or ejection fraction less than 35. But
Maybe
prophylactic preventive associated with
pacemaker
the
for
heart
heart
failure.
failure, not
Yes.
ICD. Yeah.
Heart-
Yes. Yes.
Actually, if you go for that heart failure, mainly actually cardiac resynchronization therapy, that is mostly
Yeah.
going with the heart failure. When optimal medical management failed, and also grade 3-4 heart failure or prolonged QRS or ejection fraction less than 35, that is mostly going with the cardiac CRT therapy, I mean cardiac resynchronization therapy. But ICD mainly for arrhythmia, like dangerous arrhythmia,
Yes.
VTVF and
Yes. The
Brugada,
congenital causes
HOCM,
and
like that.
the disease
Yes.
causing arrhythmia. Yes.
Preventive and
Mhm.
treatment. And
Dr.
pacemaker usually
Aisha,
using
continue,
The
continue,
treatment,
doctor.
yes, the treatment case, can you mention again for treatment?
yes, Dr. Atif will mention. Hello.
Yes,
No,
she asked you
I ask
what
you,
the
yes,
indication, yes. Indication of
indication as a treatment. Prophylaxis, I think it's easy, but as a treatment, which one?
non-sustained VTAC.
Non-sustained VTAC. Okay.
Don't forget, Dr. Aisha, you mix between the heart failure and the arrhythmia. ICD mainly for arrhythmia, but
Yes, yes,
heart
I
failure,
noticed that. Yeah.
CRT.
Yes, it is
ICD
Cardiac-
mainly for
yeah,
arrhythmia.
yeah.
Yeah,
ICD mainly for arrhythmia, CRT mainly for heart failure,
exactly.
and
Yes.
pacemaker
Pacemaker for
mainly
the
for heart
complete
block.
heart block.
Heart
Yes.
block. Not only complete, even Mobistep to
Mobis
secondary
to
heart
yes.
block complete,
Yeah.
or trifascicular, bifascicular block.
Yeah, but the most
And all the
common is
yes,
complete. Yes.
complete heart block, exactly.
Yeah.
All the device you can found in the left infraclavicular space, so it can be any device. So like that, like ICD or pacemaker or CRT, like anything.
Okay. So CRT is cardiac resynchronization therapy.
Yes, yes, thank you.
It's one of the indication if the ejection fraction less than 35% and failure of anti-failure medication. So resistant heart failure, although you started many lines of failure or anti-failure medication, then you can think about CRT. Okay.
Mhm.
Any other
Yes.
questions? Thank you, Dr. Awatif and Dr. Tanvir and Dr. Aisha. Of course, your question today added more to us. So valuable questions. Prefer to have questions from examiners or from exam experience, because we don't know, every examiner have or has his wishes to ask. Some examiners ask about the finding, some examiners ask about the investigation, and some examiners ask about the management, and everyone has his preferred answers. Hopefully we can satisfy them, but please be systematic while presenting. Yes.
معلش, if you can comment on my
Yes,
commenting.
you did perfect. Although you didn't reach diagnosis because also you didn't notify the patient age. I was with you the same. I thought it is VSD, by the way. When he mentioned left parasternal, I suspected
Yes, very
the
nice
VSD.
identification.
Even I wrote harsh systolic murmur. By the way, it will not be parasternal, rather than it will
See
be
that VFG usually not whole pericardium you will found.
Sorry?
This whole pericardium, GSD usually it's not found in the whole pericardium. I said
Yes,
whole
okay.
pericardium, but mainly in the left lower sternal area.
It's not lower sternal. It will be in the third left intercostal, which is the
Left
second.
parasternal area you can found more, but even you can found in the whole pericardium. Aortic stenosis and hookah murmur usually you can found in the whole pericardium.
Yeah. And also, by the way, Dr. Atif, if you mention the systolic murmur as a differential and you put the HOCM as a second differential, you might get good mark. But I think in the exam, they need the differential and the top your case because it's clear by the murmur auscultation finding. You have to mention the first differential. But anyway, you did great in the examination steps. You did it well.
But
The
this very
presentation.
very strange case. يعني the murmur in the peristernal, and also there is other murmur that maybe might regard associated with the hookah.
Yes, it is. I thought I sent
This is
picture
the
now.
sound.
Sam,
Okay.
Mr. Ash, or Mr. Sam Ash. Mr. is mitral regurg. It's commonly associated because of the subaortic stenosis make it the pathway of the valve of the blood narrowed. That's why you will have mitral regurg. This blood will go back with back pressure to over the mitral. It will be regurged. Okay.
Yes.
But anyway, it's better to know the case today than surprised by the case in the exam. Really, it's good experience. Thank you, Dr. Tanvir, for this case. It's a not common one, and good to know it in the sessions rather than in the exam.
Thank you very much.
Thank you, Dr. Atif, also for presenting. Although you don't prepared, but you were ready, and you prepared also the case in short time, which is difficult. I know. Thank you, everyone. Appreciate it. Also, Dr. Tanvir, appreciate it. I tried, as I said, to make the session related to one station. So the discussion will be related to the same system, not to be distracted by other system. And we will do it in everyday manner. I mean, for the next time, it will be chest. So the discussion, all discussion will be about the chest cases, how to examine, how to approach, how to present, how to answer the questions. Let's read the comment quickly. Indication of ICD again, please. Yes.
One comment I have that as Dr. Afif said that why coming with MR, it can come anything. Multivalvular heart disease can happen. You cannot think or you cannot tell why it's coming together. Yes, can come with the AR. Yes, come with the MS. Yes, can come with the MR. Anything can happen, but which is more prominent, you have to give more priority to that. And which is
Yes.
less prominent, usually examiner will not make you fail for less prominent. See, in my last exam, I got typical aortic stenosis. Typical. I said this is aortic stenosis. I will not move from aortic stenosis. Then examiner asked, did you get any other thing? Any other thing? I said maybe any other valvular heart disease may be present, or maybe it's Galaverdian phenomenon. I mean, in the Galaverdian phenomenon, you can found in the whole precordium murmur. So it's mainly aortic stenosis, but due to Galaverdian phenomenon or any other valvular heart disease, maybe another valvular
Yes.
heart disease can
Yes.
associate it. But my
Exactly.
first differential is aortic stenosis. I get the full mark out of 2020 I got.
Yes.
And they
Yes.
say
Exactly.
aortic stenosis is the main thing and associated with the MS. So for the MS murmur, they don't give me any reduction because the MS
Yeah.
just only there is a MS murmur, no other thing going for MS. But for AS, everything going with the AS.
Yes.
So
Exactly.
if you the main thing, if you can diagnose and what are the simple or not significant, they will not make you fail or not detect much reduction number.
Yeah. Again, as a general advice, if you have young patient suspect congenital heart disease, if you have elderly patient suspect stenotic or calcified or degenerative, and the patient might be with replaced valve. Congenital heart disease, already mentioned today, the HOCM. We can also have a VSD, we can have Eisenmenger syndrome, we can have ASD. We will discuss it in the next sessions. But This is the most common in young patients. Read the age, concentrate about the possibility of your differential in younger age, and in the elderly age you have to put the degenerative or non-functioning or sclerotic or whatever, but it will not be congenital heart disease. Okay, this is the last advice. Thank you, Dr. Awatif, Dr. Tanvir. Really, it was a nice session, nice cases. I think the comment the same related to our case. We already mentioned most of them. I will repeat only the HOCM murmur. The HOCM murmur increase with squatting, and because I mix, and decrease with Valsalva because of the blood flow in the squatting position. The blood flow will be more through the valve, so you can hear the murmur. And in the Valsalva, because of Valsalva maneuver, the decrease venous return, so no blood or low blood, then the murmur will be less. Okay. Again, thank you, Dr. Tanvir, Dr. Awatif. Thank you, everyone, sharing with us, Dr. Aisha and Dr. Rashid, Dr. Maha, everyone. I hope I didn't forget any. We'll see you tomorrow, inshallah, with the long clinical consultation day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.